You're listening to the second season of Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carol Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Carol Wysham. Welcome to the second season of Medscape's In Discussion series on type 2 diabetes. Today we'll be discussing the treatment of older adults with diabetes. First, let me introduce my guest, Dr. Medha Munshi. Dr. Munshi is the director of the Joslin Geriatric Diabetes Program and associate professor of medicine at Harvard Medical School. She is also a staff geriatrician at the Beth Israel Deaconess Medical Center in Boston. Welcome to In Discussion, Medha.
Thank you very much, Carol. It's a pleasure.
I always like to ask each of my guests an icebreaker question. So my question to you is, given that this field did not occur when you started your practice, how was it that you became interested in taking care of older patients with diabetes?
A short answer is that life happens. So it was purely by accident that I did my endocrine fellowship first. And for a variety of reasons, I ended up doing geriatrics. And I really didn't have a whole lot of understanding of what geriatric medicine was when I did that in 1999. And then once I started looking or taking care of older adults, a lot of my colleagues started sending me their patients with diabetes. They knew that I had an endocrine background. And as I was seeing more and more older adults, I just loved it. I just completely enjoy taking care of and talking to them. And the second thing I realized that there was a difference between how my patients reacted or were responding to what I was doing, and there was something else going on. So I started looking more deeply into what else was going on, the basic principle of geriatrics that treat the whole person, not a disease. And then when we moved to Boston in 2001, that time Joslin Clinic did not have any program. And Dr. Abrams and I went to talk to him and said, could I work with one of your educators and dietitian, because I know that this population require a different approach. And his answer was, we don't have any, but why don't you start? And that was the step that I needed to get into this.
Very good. So before we discuss treating older patients with diabetes, let's define an older adult. How do you define that?
There are so many different ways that it has been tried. And I think the easiest definition came from where Medicare starts. So in United States, Medicare starts at age 65. And so most of the people thought that, 65 is a good age or good number to start in older adults. What I've seen, though, is that it's really age in number is really not a good way of defining what aging does, especially in context of diabetes. And so when the American Diabetes Association developed the consensus report in 2012, there was a lot of discussion about what should we put as the older adults. The thinking was that older adults are like pediatric age group, right? If you think about people between 11 to 14 years of age, they are so different in how their body is, their physical and mental health. Similarly, in older adults, it is not the number, but how they are. And so the goals and sort of how diabetes is managed is sort of made more in the context of what else is going on. What is their cognitive capacity? What is their physical ability? What are the other comorbid conditions they have? So I think that is one side of the question. The other side, if you ask me as a geriatric diabetologist, when I think people need to be careful with aging, I would say in Western countries, in United States, it's probably somewhere after 75 that I would start looking for any age-related issues, even if the person that I'm talking to looks absolutely fantastic.
So that's very interesting, and it actually leads really quite well into the next question, which is, what are the challenges that you and other healthcare providers face when you're dealing with the older adult? And specifically, how do we put frailty and life expectancy in how we define our targets for these patients?
Yeah, I think the first obstacle was just convincing clinicians that they need to look at the aging population differently. In the world of diabetes, we are very aware that we don't treat a kid like a 40-year-old person, right? We know that the goals are different, that how body reacts to medications is different, or how the medications affect the body is different. For a long time, the problem was that trying to convince people that you don't treat a 90-year-old like a 40-year-old either. And the biggest part of that is, thinking back to why we treat diabetes, major focus of managing diabetes is that it causes complications over long term. So when you talk to a 20 or 40-year-old, there is a different time frame we are looking at versus somebody who is in the 80s and 90s, and how we worry about them developing complications. The other way diabetes is very different from other chronic conditions is that the safety window is very tight. So thinking about high blood pressure or cholesterol levels, and you put somebody on a medications to lower the numbers, we know that too low a blood pressure or too low cholesterol can be difficult, but it is not as big a problem as hypoglycemia. So over treatment of diabetes then can lead to too low blood sugar, which we have realized that in this population can be a much bigger problem because the consequence of hypoglycemia are much worse. So I tell my patients that when you are 40 years old and you have hypoglycemia and you lose your step and you fall and you get up and go, my 85 or 90-year-old patient with hypoglycemia, if they miss a step and fall and get a hip fracture, we have sort of defeated the purpose of managing their diabetes. That's a major problem.
So I think it's a good time to really discuss what you think the targets for glucose control should be in older adults and how you define perhaps different levels of treatment targets by their frailty or life expectancy.
Yeah, the one thing that is, again, talking about how hard it is to understand or manage this population is that one side of the coin is that how variable the patient's clinical picture is. So, people who have frailty, as you mentioned, people with cognitive impairment, people who have multiple comorbid conditions which are limiting their life expectancy on one side and making it difficult for them to do the self-care behaviors that they need to do for their diabetes management on the other side. So checking finger stick readings on a regular basis or giving injections on a regular basis, that makes the one side of the story. The other side is also, it's a very heterogeneous population in the sense of where you find them. So, as we think about goal setting, if the patient is living in their own home, in a community, is the patient living in, say, an assisted living facility or some supervision that is provided where they live? That's another area. Whether they are in the hospital or they have just gone to the rehabilitation facility, that's another area. And then if they are in nursing home. So we need to pull all of those information together and synthesize to then finally come to the idea that what should be the goals for their diabetes management. And again, I know that the Endocrine Society recently came out with guidelines for setting up the goals. So at basic level, I think we understand that people who are intact in cognition, they have ability to take care of their physical function or less comorbidity, should have a little tighter control of diabetes because their life expectancy is longer. We want to prevent complications of long-term diabetes versus somebody who has moderate to severe cognitive impairment. They require a lot of help with their day-to-day activity, or they have severe comorbidities, then they should have liberal goals. We do put numbers at that level about whether the A1C should be less than 7.5 in the healthy group, less than 8 in the intermediate group, less than 8.5 in the poor health group. I think for majority of the clinician, what I would like them to know is that think about this, and then the best goal one we can achieve without putting patient at the risk of hypoglycemia. That will be my way of thinking.
Well, actually, that brings up another question, and that is the question about whether there should be a floor. If you have an A1C, for instance, in your intermediate group that is less than 7, would that mean we should be backing off on treatment?
Yeah, and that is a very good point. And I know that Endocrine Society tried hard to do that. My worry with that, and that's a good idea, no question about it, that there is too much of a good thing as we are talking about it. The problem is that when we put a higher and lower number, it becomes very difficult to land on that one particular good place. The other issue that I really struggle with, and I know that it's not an easy thing to talk about, is that how accurate hemoglobin A1C is in older population. And I'm really worried that for variety of reason, lot of conditions that this older population suffer with, like anemia of chronic disease, multiple infections that occur over off and on, even flu or UTI that causes hyperglycemia and then pulls the A1C to high, or anemia, blood transfusion. Many conditions that change the RBC lifespan or turnover can impact the hemoglobin A1C. So hemoglobin A1C in a really frail population is really not something that I am very comfortable putting my money on. And then also the excursions are not identified by A1C either. So we have shown in many of our studies over and over again that people with even high A1C over 8% have multiple hypoglycemic episodes. So some of it is, that's the reason why I worry about making the range of A1C goal very tight from upper and lower level. So the other way of thinking about it is that if someone is on medications that have low risk of hypoglycemia, then that might be easier to manage, with a less than certain number of A1C. If they are on their medications that have high risk of hypoglycemia, then even high A1C is not actually, that doesn't take away the risk of hypoglycemia. So my message would be to look for excursion, to look for a risk of hypoglycemia rather than identifying the tight A1C range.
That's very good. I know that you use a lot of continuous glucose monitoring in your patients. What about using it in patients who, say, are on sulfonylurea or just on basal insulin? Do you use the professional CGM in that setting if you can't get approval for the personal use?
I do. In fact, I like professional CGM on almost all my older patients where I'm not sure about their ability to do finger stick readings or their ability to eat on consistently, whether they are missing meals or they are on, as you mentioned, the medications that have high risk of hypoglycemia. When somebody says older adults, the population that I see in my geriatric diabetes clinic is sort of more extreme. So in my mind, it's more about people who are much more frailer, older, and even if they are on multiple insulin injections, many times they are not able to use real-time CGM accurately or effectively. Having professional CGM gives me an understanding of what their excursions are, what their pattern is, and how I should change my regimen to not only simplify their regimen so they don't have as much burden of therapy, but also where there is a risk of hypoglycemia. And if they are okay otherwise, if somebody is on sulfonylurea and their excursions are high, I might want to change it. If they don't, then a lot of times I leave it alone for now.
So, for the audience, besides being on insulin or sulfonylureas, what are the other risk factors you look for patients who might be at risk for hypoglycemia or for us over-treating their diabetes?
Yeah, so the biggest concern that I as a geriatrician sees is that in older adults with type 2 diabetes, the cognitive function that is most commonly affected is frontal lobe function. And frontal lobe function, it controls the behaviors such as insight into the problem, stopping old behavior, starting new behavior, problem solving. So many a times these patients have very intact memory. And so the problem is that when you sit in front of them, it's very difficult to identify that these people are having problem. They can, you teach them something and ask them to repeat them, they can completely repeat it back. And then they go home and then they do not change anything. And then they come back and you say that, didn't we talk about it last time? And they're like, oh yeah, I did. And you told me this, I'm going to do that. They go back home, they come back without any change. That is a big red flag for me, because the best part of managing older population is that they actually do what you ask them to do. They understand that they are not immortal. So when somebody starts not following things that that they would want to, that's a big red flag. Someone who says that once in a while they miss their medication, that's a big red flag for me, because that's what they remember. How many times they forgot something that they don't remember. Someone who has suddenly changed their glycemic control, whether it's too tight or too poor, those are red flags for me. And then people who live alone in general, I really worry about that, because over and over again, I have found in my primary care practice that when someone goes to their home, they realize how bad things can get, that nobody knows about that. So these are some of the scenarios where I would want to do a professional CGM to see what's actually going on.
I think that's really very helpful. Hey, before we end, would like to have a brief conversation about how you change your approach to cardiovascular risk factor management, something I know that we've discussed recently. What's your view on that?
Yeah, no, anytime a new set of medications come in, I'm a little bit worried about that, because, as you know, majority of the studies still do not take older adults in their, they are not part of the overall cohort. They are sort of a subpopulation with a different type of analysis. So I was a little bit worried about, medications like SGLT2, SGLT1 receptor agonist, going backwards, GLP-1 receptor agonist and SGLT2 inhibitors, having whether they are going to cause too much of weight loss, because that's another thing that it's kind of different in how we worry about older adults, where it's not so much about obesity, but too much of a weight loss, or UTIs or genital infection and so forth. But what I have seen over past years is that they are very well tolerated. And also the data have shown that the impact of using these medications in people with a cardiovascular risk or congestive heart failure has a tremendous benefit. So people who are sort of a right cohort, I do like to use that. And again, not having hypoglycemia is a huge benefit. I do think, though, that we really like, especially SGLT2 inhibitors, that there are some, I have had experience with euglycemic decay, and that's kind of very frightening in older adults, and even in type 2. And so we need more data. However, I do think that the data as far as the cardiovascular risk factors is tremendous, and I'm really excited about it.
I think that's great. We obviously need to be careful about side effects of our other medications, blood pressure lowering and statins as well, since they can have their own challenges in older folks. Well, I want to thank you for your very good conversation that we've had about this burgeoning area that we all have developed interest in, and that is caring for our older adults with diabetes. I think you've really helped us understand how to look at our older patients as a heterogeneous group, which I think is going to be very helpful in setting specific targets, whether it be for blood pressure, for cardiovascular risk reduction. I do want to thank the audience for joining us today. This is Dr. Carol Wysham for In Discussion.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carol Wysham. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.